Welcome to Psych Incubator, an eminent psychotherapist revealed. I'm Jeffrey Magnavita, and along with my co-hosts, Kristen Osborne and Michael Albert, we are pleased to have as our guest tonight, Dr. John Santopietro. John is I would say an eminent psychotherapist. He might disagree with us, but John is the first physician-in-chief of the Hartford Healthcare Behavioral Health Network, Connecticut's leading provider of addiction and mental health services. He's a nationally recognized leader and previously served as president and medical director of Silver Hill Hospital. Prior to that, he was chief clinical officer for behavioral health and chair of the Department of Psychiatry at Carolinas Healthcare System, one of the nation's largest not-for-profit healthcare systems. He has published and lectured extensively, especially on the use of technology to enhance the delivery of behavioral health services and integration of behavioral health care into primary care practices. John is a close friend and esteemed peer of mine. We've worked together over many years, and we'll get to talk a little bit about that today. So, Dr. Santopietro, welcome to Eminent Psychotherapists Revealed.
Great to be here. Thank you. Thank you.
It's wonderful to have you here, John. And I'm just wondering if there's anything that you would like to share about yourself that Jeffrey didn't cover in his introduction.
Well, I'm glad whatever bio we gave you, Jeff, only had a couple of jobs in it, because I've actually worked in 12 organizations in the span of my, 25 plus year career, which is in itself kind of a story. I guess, maybe just to start where it starts. I grew up in a big Italian family in Rhode Island, which is a small state, and so everyone was always sort of gathering in groups and talking in each other's business. And my mother taught at a private Quaker school, so we could go for free when I was a kid. So I went to a Quaker school from kindergarten through 12th grade. So I'm sort of built by Quakers and Italian family stuff. And Quakers are very inward looking. We had silent meeting, when I was in, second grade, all the way once a week. And people would gather in a group and sit in silence, but anybody could speak. So it was very, I was sort of primed, I think, to do something in the field. And when I was in college, I did actually, my senior thesis was on psychotherapy, which is maybe the only official paper I've written as a senior in college. It was called Good Psychotherapy. I was on the power dynamics and the ethics of that in the therapeutic relationship. I'd never been in therapy before. I mean, what happened was I took a course on Freud, and as a sophomore in the philosophy department, and we read The Interpretation of Dreams, and it was taught by Jonathan Lear, who's a very eminent psychotherapist and psychoanalyst now in Chicago. But he was the youngest chair of the Department of Philosophy at Yale, like ever. He was like 35 or something, and just so charismatic. And so I was sort of carried away, and then so decided later to go to medical school to pursue psychiatry. So I took a year off, was in San Diego, finishing courses, and then got really good training. I after medical school at Northwestern, where the only other thing I thought about was surgery. And if you're interested in my thoughts about the similarities, I'm happy to talk about that. But didn't get derailed, and then trained in Cambridge at what was called the Cambridge Hospital. Now it's called Cambridge Health Alliance, and it's a Harvard program. And back when I did it, you could do a combined program with the Austin Riggs Center, which is a very actually psychoanalytic treatment center, hospital, and residential and outpatient treatment center in Western Massachusetts, where I am actually I'm involved. I'm on the board now. That's been an incredibly important source for me of inspiration and a sense of sort of true north about the work. I think that has really informed who I've become in my different roles, but also at Cambridge Hospital. Back when I was there, a lot of the people that had been at the Mass Mental Health Center that were trained by Alvin Semrad, who wasn't around when I was there, but Les Havens and John Mack and Myron Sheriff and so there was a kind of a deep psychodynamic sensibility, but also a community psychiatry sensibility, which I think primed me for this derailment. I feel like we were joking a little bit before that there may have been a pathway where I would have been, so I would classify myself as a psychotherapist now, which I kind of don't exactly do, and maybe even eminent, but I was derailed into being obsessed with trying to make the system better. And that happened in my first job, because my first job was in inner city hospital just outside of Cambridge, or just outside of Boston, actually, in Dorchester. And I was not at all planning on doing leadership or administrative stuff. And but I couldn't believe how broken the system was and still is. I hadn't seen it. I don't, in training, you're in some other kind of a mental state yourself, and I just couldn't unsee the broken system. So I describe it as I was afflicted with, I couldn't stay out of the fight to make things better. And that was in 2000, and so I got involved in leadership right away, because that's I complained about things for like 3 months, nobody did anything, and then I got involved in leadership, and in one way or another I've been doing leadership since then, for 25 years, and I've worked in 12 organizations. That actually goes back to residency, but I've been in community mental health, 2 community mental health centers, state psychiatric hospital, community hospital, inner city hospital, big system down in North Carolina, Silver Hill Hospital, which you mentioned, Jeff, where I was the CEO for a brief period of time. And now I'm the physician chief of behavioral health at the Hartford Healthcare System, which is a big not-for-profit system in Connecticut. And behavioral health is comprised of 3,000 people, believe it or not, working in behavioral health every day, 4 major campuses, a lot of other stuff, education, research. So my sort of leadership work career is about trying to work within a system to bring the best care to the most people. I mean, it sounds really simple, but it's actually really hard to do. And as it relates to the clinical work, I've always done clinical work. I always had a lot of patients up until my jobs got really big. This is a pretty big job. So I probably am about 10 to 15 to maybe 20% clinical now, but it is the thing I love to do more than anything. Like it is the thing that does not feel like work to me. There are times when leadership feels like work. I mean, I love that work too, but anyway, so that's sort of a few things as a primer.
What is it about psychotherapy that you enjoy so much?
Well, that's a good question. Jeff and I were talking a little earlier about this idea of what is a calling, what is an avocation, what is and I'm at this stage in my career, right? I'm, 55, almost 56, and I can kind of imagine at some point I won't be able to work forever. What are these next years going to look like? And so I've been thinking about it more, as I've had to really think about, what do I love doing more? And I sort of feel like I can't not do that. I mean, there's something about a calling to do that. First of all, it's fascinating. And the longer you do it, I think the more fascinating it becomes, and in some ways the better you become, because it's accumulated experience that informs it, in the sense of being more and more in a moment with somebody and not encumbered by all the things early in your career, the doubts, of course, but the mistakes that you inevitably have to make, and that sort of genuine, sort of almost one-pointed meditation you're doing with people. It's just really invigorating. Plus, the inspiration I get from the patients is like, there's nothing like that. Even in all of the great leadership experience I've had, nothing comes close to. I mean, I can pull in my mind some of the patients I'm working with now that I just can't imagine how they've survived what they've survived, how they work so hard, to recover. those are some of the thoughts that come to mind.
One of my good friends uses the word wonderment, and I think of that as you're talking, John, that you have that, if that isn't even a word, wonderment, but
Yeah.
you get it, that you have that, and you're probably one of the most passionate psychiatrists that I've worked with in my pretty long career. And I think that, you know, in our work together, there's a lot to it. But one of the things I try to see if I can figure out is what makes you do what you do, and why do you care so much? I mean, it's like you care so much about every patient. Don't you run out of caring? I mean, you every time you call me with a new patient, you're like you really I go home to Annie, my wife, and I say that John Santopietro, like he actually cares about the people that he's working with. And I guess to say that is kind of sad, because that means in my experience, a lot of people don't either
Yeah.
they don't feel it or they don't show it. And it's sad.
Yeah, there's a lot of ways this can go, right? From this point, right? Including the, sort of an indictment of psychiatry. And I mean, and I really, because, and I've joked about this with you over the years, Jeff. I mean, I'm surprised at how low the bar is set for psychiatrists. Let's just kind of say that for a minute, picking up the phone as a psychiatrist, and not, and this is not about, people not wanting to do great work and not being wonderful people and actually doing good stuff. But there's something that's happened in the fragmentation, again, back to the system and what are the expectations. And some of it is risk management issues. Some of it is interdisciplinary,
Rivalry.
stigma issues, whatever. But let's stay off of that, road for a minute. I mean, the other way I thought about it, and we were talking a little bit about this as well. I mean, a friend of mine says there's three kinds of people in the world, in the working world. There are makers, there are takers, and there are helpers, and that's always stuck with me, So I think we are all in the third bucket, and so I've, flattered by, the compliments about me, but also I think I get to sit here for a minute and represent that there are a lot of people that are kind of born to be helpers. I think many people would almost want to wish it away, because you can't turn away from. And actually, it brings to mind a patient I'm working with who is further along in life and reflecting, and is the kind of person. One of the things that they're reflecting on is their inherent tendency to not be able to look away from suffering, which is something that they're really internalizing as a good thing now. I mean, it's had so. But just to speak for a minute about the work with you, I mean, and this may be worth talking about because I don't think we do enough of it. I don't think we do enough team-based care, TEAM based care. There's a lot of literature that supports it in psychiatry and but especially, in private practice, in the private practice world, people get so isolated. Even in system-based care, people are so frantic chasing, all of the work, the busy work that they need to do, that there isn't time to do team-based care. When I was in one of the systems that I was in, actually a number of systems, I've brought in the idea, believe it or not, of having a team. Like some of the places just don't even have teams, and bringing psychiatrists and therapists together in a team. Oh, we can't do that. We don't have the time. Well, we can take an hour a week. It's not, and maybe it's going to make some of the things more efficient. And literally, there's one place where in the outpatient department, the psychiatrists were in the basement and the therapists were on the first floor, and people were so nervous about having team meeting. We had to have mini team meetings at first, and And then we had these teaming, and there were conversations like, Dr. X, it's so great to meet you. I've been here for 3 years. I've seen your notes on patients, but we've never met. I mean, just think about that. So, I think I think it's better care for patients for a variety of reasons. One is they have the experience of being known, seen, cared for by a team, or in the case of you and I, working together by a dyad. I think it helps you bear, the pain of and the confusion and the anxiety of the work. There's probably a bit of a corrective emotional experience, aspect.
We do some pretty unusual things as well. But one of the things that we do is that sometimes I call you when I'm with a mutual patient, and you pick the
Right.
phone up and I put it on speaker. And I think that whole experience is what you're kind of talking about, the
Right.
idea that here are these two people that not only talk to me, that take time to talk to me in the session, but I know they talk about me outside of the session.
Right.
And that to a lot of people, I think it amplifies the potency of the therapeutic relationship, because it is a corrective emotional experience to have two people who are, it's like having two really good parents that are
Right.
solely interested in collaborating and helping you be the best you can be. And
Yeah,
and
exactly.
that's the idea. Like, we're really interested in you being your best self.
Exactly. And to the extent that any of the work is about shoring up ego strength, right? Like it mitigates that I only exist in the room with you, and then where does that go?
Right.
Because we're kind of connecting in a triad in a sense, and that experience, and I call you too, from, it's the other thing about that, as I'm thinking of it, is that then I can say to you,
What do you want to say?
something in a different sort of voice, right? And it's kind of a riff on mentalizing, right? Because you're
Yes,
sharing with this colleague, your mentalization of the of
the
the
patient.
of the patient in front of them, which is sort of really interesting and fun. I think part of it's really fun to work in a team
Yeah,
too.
it's really fun. It's much more fun than the isolated um, sort of model.
So why don't more people do it?
That's a great question.
Am I supposed to answer it?
No, I'm actually thinking about it. Why don't more of us do it? I think sometimes, well, it has to be two people who are interested, at least two people who are mutually interested, because if one person doesn't have time, they don't pick up the phone, they don't call back, they don't give you, a lot of people won't give me their cell phone, other
Right.
doctors, other psychologists won't give me, so it's very hard. If I have to call through their answering service, I can't do that very easily. So I give people my cell phone. It's like, call me, and if I'm not available, I'll call you right back. And if I'm
Right.
available, I'll pick up. But it's the idea that if you two people have to want to have that shared kind of therapeutic agency, I think, is the
Yeah.
first one part, right?
Yeah, I mean, I agree. I mean, I think some part of it is we've I don't know, we've all become more focused on our phones, in life. I mean, we're sort of like, the Galapagos Islands, like species sort of drift apart. We're in our own worlds. We're getting our own news feeds. We're less sort of connected, maybe in general, less likely to pick up the phone. Try calling your kid these days, right? They don't even pick up the phone. They just
Oh,
it's got to be a text maybe or whatever.
right.
Instagram or something. And so there might be that factor. I also, as you're talking, I was wondering about there used to be, I mean, I don't know, this may be just my fantasy, but if I think about my training back in the late 90s at Cambridge Hospital, at Austin Riggs, there was a lot of exposure of your work, right? So, even on inpatient units, we met as a team, and you brought your patient into the room and you interviewed your patient in the team. And you watched other people interview, and we had case consultations all the time when people were interviewing in group settings. And then at Riggs, we had a 2.5-hour case conference after if the first month of therapy that you were seeing the patient, and you would present the psychotherapy for 45 minutes, and so I don't know that people are growing up in training with as much exposure of their work, or a sense. I could be wrong about this, but I wonder about it,
I think you're
So
right.
the idea of like sharing one's work, like I feel very open about my work, um, because by definition, if someone's still coming in to see me, they're not better. So, I haven't figured it out, and maybe somebody can. And B, this humility, around, as of today, we have no blood test. We, as psychiatrists now, right? I'm speaking. As of today, no blood test, no head scan, no nothing that says this kid has bipolar disorder. So, and then you've got 100 billion nerve cells and 10,000 synapses per cell. It's 100 trillion,
Connections.
synapses.
Yeah.
And how in the world do you think you've got it all figured out without, kind of having a team jump in? Anyway, I wonder a little bit about training. I mean, I don't know. Kristen, I know you're involved in some training, I think, of psychiatry residents, right?
Yeah, I work primarily with psychiatry residents, and but the training that is coming to my mind is core training that I've done, where there will be like 8 to 12 students that all meet together in one room, and students go one by one to present the video segments of their work. And so they're one-on-one with the supervisor, but then all of their peers are watching the video segment, the supervision. And I think that's been a really difficult way for them to learn, but it forces them to grow so much, and everyone's learning together case by case.
Oh, that's good then. And is your sense that that's common, or that's more on the unusual side to have that much?
I think it's unusual because it's more expensive. I mean, people have to be in the same city in order to meet live. That entails hotel rooms and restaurants. So I think someone's really fortunate to have that opportunity, but there's not many of those opportunities around. And a person has to go out of their way to get it. Otherwise, like with my residents, what I'll do sometimes is, instead of one-on-one supervision, introduce that group supervision. And of course, everyone wants the one-on-one,
Yeah.
but so much magic happens when you have like 2 or 3 residents
Yeah.
in the room at the same time, looking at video segments of psychotherapy and learning together.
Yeah, I'm so glad to hear that that's happening, even here. So I'm at the Institute of Living, and I should know more about the residency program here than I do. I get so caught up in the doing and the building of system stuff and that sort of thing. But I know, for instance, that we have, one-way mirrors that we don't use anymore,
Right.
and every once in a while there'll be a grassroots effort to say, hey, let's get those going again,
Right.
We have one built into our office here. Our office
You do?
next to where you occasionally work. Yeah, we used to do live interviews and behind the one-way mirror.
Yeah. Well, I remember, Jeff, I think you used to, I don't know if you still do this, but video your sessions, right?
Yeah.
I mean,
I
like
had-
from
I-
2 angles.
Yeah.
Yeah. That that kind of, really digging deep into the mechanics of the work. I just don't think, or even the APA series that you were involved in, a number of years ago now. I don't know if they're doing anything like that.
They still do those. And I think the what you were talking about, John, the getting together and doing live interviews, I think a lot of that has been lost, because we used to do that in our training as well. And I train in family and in short-term dynamic. So we would do either live interviews or video in short-term dynamic therapy. If you couldn't show it, it wasn't considered worth talking about. You had to really show what you were doing so people could engage in a discussion about it. And
Yeah.
Yeah, I mean, a lot of people were very, very committed to learning and would truck up to Montreal for these conferences where we would watch.
Yeah.
We watched Davenlou used to do these conferences. They were all week. We would watch video all day long of his patients, and then we'd go back and we'd video and go back and present them as Kristen was describing in front of the group we present. And I remember one time I was in a supervisory group with Davenlou, and we went out for lunch, and I went into this store and I found the head of David, a big bust of David.
Yeah.
And I brought it into my supervisory session, and I put it on the floor because Davenlou was like very intimidating to get supervised from. You would have a spot to present, and you'd have an hour, and if you screwed up at the beginning and it was going south, you kept watching the tape the whole way through. You would be in excruciating state of humiliation for an hour. But it was all like part of desensitizing us to our own kind of affect phobia, as Lee McCullough used to
Interesting.
call.
Yeah. Well, it's interesting. I mean, it reminds me a little bit of the Riggs, training, not as intense, but, when as a fellow, because there were a lot of really experienced analysts there that were, so when a new patient came in, they'd either get assigned to one of these amazing, analysts or a fellow, and so there was always this sense of, being beneath, what was considered best practice, let's say, and presenting your work and routinely, either when you were doing it or watching your other fellows do it, when you would present at the case conference, and whoever was leading the conference, usually it was the CEO, medical director, Ed Shapiro at the time, who was a phenomenal analyst and interviewer. And he would inevitably, without exception, so what you would present, everyone would present, and then the patient would be invited in, and then he would interview the patient, and you had to sit behind him so the patient could see you through him and all this, and he would inevitably, within like 20 minutes, usually within 10 minutes, have figured out something, or have gotten in, beyond, behind defenses that you hadn't even seen. And there was a little humiliation involved. I mean, or this sort of, intense awareness of how much you still had to learn. Let's put it that way. What it has me thinking of, and again, I bounce back and forth from the work to the system, because most of my career energy has been around trying to make things better incrementally, usually in the system. But one of the things that's astonishing to me, so I've hired hundreds and maybe even thousands of clinicians and psychiatrists in particular. Never once, not even one time, had I seen the person interact with a patient beforehand, and for 99.9% of them, not even after. Right? What a weird concept. We in healthcare, we actually just had a big event, and we had somebody up on stage who's a surgeon, and because we've done very well in terms of quality for certain kind of surgery, and he is in a role. He's in my role basically for cardiac surgery, and he famously goes and sits in surgery. Because in surgery you can do that. You can sit alongside, those, like, it used to be the old amphitheaters, but now you're going to just go into the OR, or you can zoom in and watches them do surgery before hiring them. It's such a bizarre, it's something that's really bothered me, and I think we've kind of gotten phobic. I'm going to say in the system, and by that I mean these big community health, mental health organizations or big, hospital-based systems, kind of phobic of sharing our work. It's uncomfortable. We have a case conference here, which is very rich and robust, but only once was a patient invited in. That's when I brought that patient in.
I did
Jeff,
one with
you and
you.
I were working with together.
Yeah. That was the only time?
Uh-huh. I mean, the pandemic hit after that, and it's been on Zoom. That's part of it. But I've encouraged that group to get back in person and bring patients in, or you can even bring them in on Zoom. But it's a little anyway.
So often we talk about what we think is helpful or not. What do you think the secret sauce is, as you would call it, that helps people heal? Like what is it in your experience?
Yeah, I wish I were more of a thinker. Like I really have a good friend of mine who gave me, she's the American Psychiatric Association president, gave me an award and said this thing about me once. She said, "You're a doer," like more, I think in a sense, more than a thinker. I'll give you my sort of current answer, but it may have been different a year ago. And my own experience of if I've had any, luck in getting halfway decent at the work, it's been by absorbing what other people do and what works and just enacting it. You know what I mean? But the way that we've talked about this, obviously, Jeff, talk with my patients about the work to try to democratize it, is to say things like, it's not rocket science. On the one hand, a big part of it's not rocket science. It's like, especially as a psychiatrist, I'm kind of like a mechanic, I've seen over 10,000 cars, and after a while, kind of no matter who you are, you get a sense of how the engine is knocking, and that points you in a certain direction with respect to treatment but also this other metaphor of it's just like going into, on the therapy side of things, it's like going into the psychological gym and working out with a trainer. Most of us, so some people are born with like perfect physiques, like their muscle x-rays are perfect, like some people, people like Olympic athletes and whatnot. The rest of us have to work at it, right? And I think the same is true psychologically. Some people are sort of born with just great psychological musculature, but the rest of us have to work on it. Sometimes you can work out at your home gym, but sometimes you've got a psychological muscle that's really out of whack. And, usually it's atrophied or it hadn't developed. And, maybe it has something to do with attachment or maybe it has something to do with assertiveness. We've talked about these things recently, or saying no, right? It's a psychological. So some part of my experience of people getting better, and I have a front row seat. Most of my work is doing psychiatry alongside, therapists, and a lot of my folks are with you, Jeff, and I get a front row seat to someone who I think is an extraordinary, eminent psychotherapist, right? And who can, as a trainer, really focus in on that muscle and work on it. And so anyway, I mean, that's one of the things that comes to mind about I mean, the old, in my training, Semradian, Elvin Semrad, his statement was that basically our work is about acknowledging, bearing, helping people acknowledge, bear, and put into perspective painful affect. I mean, in some ways it can be that simple.
Yeah, I think that was good at it.
One thing that I just wanted to kind of shine our light on is psychiatrists are experts with questions. And, I've had the luxury of being on a few teams. The team that I was on the most was up at the Brattleboro retreat in the 90s. And so Austin Riggs was where we always wanted to go for our conferences, right? And
Yeah.
we're really inspired by their work. And I was able to work with a behavioralist psychiatrist, Dr. Noor, and then a psychodynamic psychiatrist, Dr. Lebenzon, on a child adolescent team.
Yeah.
And it was just so fascinating for me to go from one team to the other throughout the day and listen to the questions they asked.
Yeah.
And while some of the questions were the same, there were many questions that were different based on their perspective. And they both thought one another were just brilliant, experts in
Yeah.
the fields, which they were. But I liked how they acknowledged one another's perspectives, but how they asked questions or what they asked, there was a difference based on their background. Behavioralists ask these types of questions, and psychodynamics ask these types of questions. So,
Yeah.
and I find every psychiatrist overlooks the fact that they're expert at questions. And when you ask questions, people get anxious and
Yeah.
then do all sorts of interesting things.
Yeah.
And
That's a
it's
great
magic.
Yeah. Well, and it mirrors my experience of training, which was, watching a variety of people interview and interact with patients and you're just listening, and then wow, something stands out. You're like, what was that? And you never, some of these things you never forget. I still literally use questions from,
Yeah.
watching somebody in residency,
So I call that finding the signal in the noise, right? You get that where
Yeah.
that frequency just you tune right in and you get that signal. And I want to ask you about a little bit about that in terms of my observation that psychiatry and psychology has drifted to a tendency for focusing on symptoms as if they are the
Yeah.
disease, right? Like it's like you have anxiety, we're gonna treat the anxiety. You have
Yeah.
depression, we're gonna aggressively treat the depression. And the more that I read and the more that I do the work, the more it seems like that is making matters worse. That actually a lot of the psychotropic medications, when they're really trying to hammer at the symptoms,
Yeah.
actually can keep the person from doing the exercise in the psychological gym because they're not actually having to respond to their emotional experience because it's being numbed.
Yeah.
And so it's just like it's counterproductive. I don't know what you
Yeah.
think of it.
Yeah. Well, first of all, I would separate out the sort of symptom-based mindset and disease, oriented mindset, even from the pharmacotherapy or the meds, because they're related, but they're different things, right? So, so there's a problem. There's a lot of complications with the fact that psychiatry exists within the house of medicine, right?
Yeah.
Where, when I was interested in surgery, it's pretty clear. There's an abscess, you got to take it out. There's a blockage, you got to open it up. And there's I think always a wish that things will be that concrete, for those of, for psychiatry, that exists within that house of medicine, and yet it's not. It doesn't work that way. Oh, hi, Michael. And not and it can be problematic in a variety of ways. One is that it can, obviously it can be a distraction and even a defense against connecting with somebody, because here we are talking about your symptoms and not about you, which is a problem.
Or what your symptoms are, like they're the smoke of what
Oh, right.
is burning within you that we need to like sort out.
Exactly. They have meaning. Symptoms have meaning, right? And no,
Absolutely.
people are not interested in that. The medications is another, it's a really interesting area. There's somebody, David Mintz, who's just written a book not too long ago on psychodynamic psychopharmacology, and he writes on this regularly. And it's an extraordinarily powerful and not often rigorously thought about intervention with people. I mean, you are literally taking, you are
Yeah,
writing.
you gave me a copy of that book. It's really good. Yes.
Yeah.
Yeah.
Yeah. And, or in the computer now. And as a dime doctor, I put this in the computer. I'm authorized by the state, and to do this, and the federal government, right, as it relates to controlled substances. I have this authority to prescribe to you a substance, a physical thing that you're going to then put in your body that is going to have effects on you, probably in your brain. I mean, that's an extraordinarily powerful thing. And, I mean, there's a whole kind of discussion that, it'd be interesting to have with him about that, but at a very basic level, just being aware of all the implications of that, everything from placebo, positive and negative placebo, to the sort of traumatic, invasive, element of it, to the sort of object relations taking in of another person,
Maternal, potential maternal.
Yeah, the caring.
Yeah, the caring. Or on the flip side, when a patient uses the medications you prescribed for them to help them in a suicide attempt, what does that mean, right? Where were you in their minds? Usually, and I'll always ask about that, and usually people say, I wasn't thinking about you at all. Oh, really?
Well, what can I ask a question? I know I'm finally got in at the last minute.
Yeah.
I came into my phone rather than the TV, but I mean the computer. What does it feel like when they tell you, well, nothing, you have nothing to do with it?
Well, I mean, I may have felt more before. I mean, to me, it immediately, is I see it as a defense, right? As
Sure.
And think about how I can ask a question a little bit better that will get to what, but if I'm getting the point maybe behind your question, Michael, I do not infrequently. The reason I had that conversation with them is to sort of signify the boundary, right? So, to bring into mind and into words something that otherwise wouldn't, exist that way. You did take medicine. You took a substance I gave you to be helpful to and heal you in order to die. That has meaning. It has meaning for me. Does it have any meaning for you? What's the meaning for me? What?
I'm to be kind of the dog chewing on the ball or something. It's what is it like for you though? I mean, because for me, when I hear that story, I get very upset. I get teary. I sad for this person. It's painful to hear what they go through and how they push away.
Yeah.
And they often react to that. They say, "What's the matter with you?"
Yeah. Yeah, I mean, I have a different natural response, probably. I get more angry, right? Because it's a boundary violation, basically. I mean, it's an attack on the treatment. It's an attack on work we're doing together, right?
And it works. They get you angry.
Yeah, well, I get it. Works for me. But back to Jeff, your question. I mean, this is a big problem, and in a consumer world, it's so easy to get a message out there that we can take your symptoms away. Oh, you have this symptom? We've got just the medication for you. I mean, that's been around for a while, that sort of ethos. But, you probably have heard about these companies that have started online, giving out stimulant medications like candy,
What's the most common symptom people have in your experience, or one of the most common?
Anxiety, probably.
And how do they experience that?
Well, that's a good question. Now that you mentioned that, I would say maybe the majority of them aren't aware of experiencing it, but people around them are. or it shows up in their behavior.
It's like
So
ego, like it's or unconscious anxiety, or just not mentalized.
Yeah. Yeah, or I'm just thinking of some people recently, but it sort of had it for so long. It's it's become syntonic. It's their resting state.
yeah. Yeah, I visited a cousin when I was in California who's about a little younger than me, but the cousin was very, very, very depressed, she said, and I said, what's it like? And she said, well, I'm anxious. And I said, what does that mean? She
Right.
said, well, I don't know. I'm just anxious. And I said, well, so I just asked for the physical correlates of it. And she said it was her neck. And then she said it was her chest. And I said, well, what's that like? And she said, it's hot and it's pressing. I said, so, I tried to find out when she first felt that way and what's it like now to have it here with me. And she said, well, I'm not sure when the first time was. I said, well, just take a guess. And she said, when I graduated from college and I didn't know what I was going to do next. So I said, well, look, so now you're feeling that here. What's it like to have that here talking to me? And she said, I don't know what you're talking about. And I said, well, when you tell me this, I begin to feel the same way. My chest is feeling that. I'm so sad about what you go through, and I can feel it because I've had my down times. And she said, oh, really? And she said, but you're going to leave me, aren't you? And I said, well, I can talk to you again by Zoom, but I can't stay here. And she said, well, that will be okay. So I'm not saying that this is magic or anything, because I know that she's been begging to be rehospitalized and get more ACT, and they're trying everything they can, but getting nowhere. And I think they're just so quick to run to the medications or doing something rather than just having people understand what this burning pressure is.
Well, I
Because
think you're making me think about another part of this, and a little bit getting back to what we were talking about, John, the secret sauce. I think we don't have the time. I mean, we do as therapists, but most providers don't have the time to be with someone long enough to help them even do what you just did, Michael, to help someone just even have like basic, like in touch mentalization, put into words. I'm scared, I'm sad, I'm lonely, I have longings or needs. And you can't do that in 10 minutes or 15 minutes, or sometimes even in
no,
4 minutes. I mean, sometimes with the people I work with, I can't even get near that. Like the first 45 minutes sometimes is just getting some resonance of safety before we can start to allow them to just try to see what they're experiencing, and then are there different states that are available. So it's we're so impatient and looking for relief of suffering and pain, and I think we wind up almost making it worse. Because
yeah,
John and I had patients who have been on anxiolytic medications for decades, higher and higher doses,
sure.
and they can't use their emotions to attune or guide or learn. Their whole emotional learning system is out of whack, and anxiety becomes so unbearable, so intolerable.
Look, I think you're right. I think we rush to get people better because we care, but really we add to the problem, and we get into this cycle of meds or just trying to push them. And I think until we enter it from a much more basic level, like a mother with her child and trying to soothe the child,
Yeah.
or
Right.
firmly hug
a
your
lot of what,
child, so that
a
could
lot
get
of what
better.
we do is adding to the allostatic load that the person is experiencing. It maybe helps in the short run, but in the long run, it's an allostatic load on their overall operating system that eventually is going to really collapse. And
Yeah.
then
And speaking of allostatic load, I saw Ken has a question in the chat about, what's going on in the world, and does that relate? I mean, geopolitically and climate change, and not to mention all of social
it-
media.
Look, all this stuff adds to it. I mean, but that actually can get you to your feelings, because we're a little more comfortable with our feelings about that part of it, because it's a step removed, and we don't have to dig at our original problem, but at least they get practice.
But this is a really good question, Ken, that Jens. And so I just want to read the last part. What are you doing in your practice to adjust to the frightening geopolitical and climate change? How's the sauce of which you speak being adjusted for the foregoing? That's an excellent question. Any of us want to try? John, do you want to try that?
As a not rocket science guy, I mean, my first thought is, in some ways, the very basic things that we do or you guys do, and Michael, you just gave an example of even on a first meeting, accepting somebody for whatever state they're in and reinforcing a sort of moment of connection, and supporting their capacity for internality, let's say, in a world that is so kind of overwrought with signal. To your point, Jeff, I mean, literally just doing that, just listening to somebody, just like, and Michael, you allowing someone to feel like whatever they're feeling, and not have to worry that you can't tolerate their feeling. I mean, I think that actually goes a long way these days. I'm thinking especially with kids and young adults, they're just so, there's such little space for them to be whatever, whatever they are.
It's really tough for them. There's no question. That's another one of those problems in that list that you and Jeff have described. All of the pressures and the isolation of living in a world that's so computerized. How many young people today can't talk to people because they have been just gaming.
Yeah. And I definitely have seen, I don't know if you guys have, I'm there, I probably have a dozen people I've seen in the last year that I've had the thought they would never be coming in if it weren't for the pandemic, especially young adults, that they missed out. It was a blank space in their development.
Derailment.
Derailed, yeah.
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 At prime times. I mean, I think that's a lot of we get with people even without the pandemic, that if you miss a prime developmental phase, like if during adolescence, like if your parent died and you're depressed or something happens and you can't get out there and exercise those psychological muscles that you talk about, John, those social muscles, then you're not prepared for the next phase of your development, and things just seem to pile on top of one another developmentally. I think we often don't take that into account in our formulations, how all of this is so developmentally keyed.
Yeah. For some reason, this is making me think back to we were talking about the benefits of working in a team or even in a dyad or a pair. It also, I think, allows you to manage the external environment better. In other words, if you're an isolated, therapist and seeing somebody in isolation, whether or not you're going to have the family in can have implications, whether or not you're going to have the friend in, or whether or not you're going to talk with the primary care provider or the whatever external sources of information there are. But in a dyad, sometimes, Jeff, you and I, like, maybe it would make more sense for someone to preserve their psychotherapy. They're separating and individuating. They don't want to bring their family into that, but I can meet with the family and even do a little bit of directed, work that with the family, directed by the individual work you're doing. I think that's another benefit of working in a team that's harder to do as an individual.
I think that, the bulk of things that come in originated early in the person's life, and it just got exaggerated more and more. Kristen started with children. That's where she started her work. What do you do with when you get these kids at a younger age? You think it makes it easier than when they're so concretized, they have a big walnut shell around themselves, or do you find it's actually harder with children?
I think it's easier with children. I mean, they're so present. And even when they're anxious and in a defended position, I mean, if you're present with them, that goes a long way with helping them relax and to open up and explain like what's happening. So yeah, I think children are much easier to work with than people have had like 40, 50 years of practicing their defenses.
Yeah.
So I'm going to get back to the idea that we just touched upon a little bit before about calling and what it means, John, for you to be a psychiatrist, and like how that and a healer and a psychotherapist, how do you feel that's like embodied in you? I mean, I know how it is because I work with you, but how would you? Maybe I know it better than you do, but maybe not. But how would you explain how you experience that embodiment? Because it's very unique.
Well, first of all, when you said calling, I thought you meant actually I pick up the phone. So I did adjust midway, thankfully. I maybe I'm going back and forth about, I mean, the other angle on it is, I mean, I was interested in it, got great training in it, got, as all of you, good at it. It's fun to be good at something, in some ways it feels like if we were good at being musicians or playing a professional sport or something like that. There's just the love of the game, the love of something you've gotten good at, and maybe some of it was you had to be born a helper, but there's
It's like Dharma. Is it like Dharma that everyone has a path to follow that will maximize their life and those around them?
Could be,
Because I remember when I mentioned this to you, John. Remember when I was in parochial school when I was like fifth or sixth grade, the nuns would come in once in a while and say, they look around the room very serious and say, some of you in this room are going to be called by God. And if you get the calling, you have to go. You have to go. If God calls you to be a priest or a nun, you have to go. And I would be sitting there and I'd be frozen in terror. Please, God, don't call me. And then I realized that maybe if there is a God, maybe God did call me, but not to be a priest.
Well, I mean, not to be too glib, but there is a sort of, maybe you used this word at one point, wonderment. I mean, I've thought of there might be an overlap. I mean, in that calling. I mean, we probably all have some. I think of it as in awe-ness, right?
Yeah,
like,
yeah.
I'm in awe. Like and it doesn't matter who I meet.
I know. You never lose it.
They could be somebody on a bus. I mean, there's just a reflexive in awe-ness of the other human, whatever that's tuning into, who knows, but it does help. I think.
Can you describe that in awe-ness a little bit more? What's the sensation and the thought of being in awe?
it feels sort of like a looking up at is what comes to mind. It's like, wow, like, how is it possible that there is this amazing, human being, so, unique and different than any other human being, and there's a curiosity in it, I guess, is a part of it. Maybe a little bit of, especially if they're suffering, a pull to try to help. But
I'm aware that we're out of time for this this evening. But John, one more. If there's one thing you could say to early career clinicians, what word of advice would you give them?
well, what came to my mind was what Les Haven said to us when we were in training. He said a couple things. He said, lie to your supervisors. And he said, have at least one patient that nobody knows about.
Well,
this was back in the day, but the spirit of that is, especially now, when the system is so broken, trust your instincts, right? Like, even though, we talked about it can be humiliating at the beginning of training, even though you may have to go through some of that, you're still going to be more right than your teachers at some point about a lot of things, and it would be something like that, I think.
Hopefully.
Well, thank you, John. We're going to have to stop for here. It's been a delight to have you. We hope you come back, and we'll hang around for a couple of minutes after we stop the recording for tonight to debrief. Anybody that wants to hang around. Thanks again, and see you next month.